Hi, everybody. I'm Sam Spiegel. I'm one of the neuro-ophthalmologists here at UC Irvine, and we have Crystal Jicha, who is one of our headache neurologists. I am a neurology-trained neuro-ophthalmologist, but I am headquartered in the ophthalmology department, while Dr. Jicha is within the headache clinic. She is the director of our headache clinic here, and she is in the neurology department. So we share a lot of patients because there's a lot of overlap in the two fields. This is a topic that I see a lot every day, and Dr. Jicha sees every single day as her primary specialty. So we're putting together kind of a joint lecture that is primarily going to be focused a lot on kind of, well, headaches, migraines, and from the patient's perspective, what can patients do, education, and well, we'll go to the next slide and I'll go through the whole thing, but we're going to trade off and go over sections piece by piece.
Thanks. There you go.
All right. So we're going to start out with just a quick overview of migraines, and then I'm going to pass it off to Dr. Jicha to talk about lifestyle and trigger avoidance. And then I'm going to cover some of the ophthalmic side of migraines, so light sensitivity and visual aura. And then Dr. Jicha will close this out with a lot of other headache topics too.
Wonderful.
All right. So why we're all here. What is a migraine? We will get into the more nitty-gritty criteria within migraine, but I think a good overview is a disorder that is primarily episodes of moderate to severe headaches, and then certain associated symptoms that can meet criteria for migraine. But if you have a moderate or severe headache and then associated nausea, light, and sound sensitivity are some kind of overarching principles. But that covers a lot. So if we look at the criteria, I think the next slide is the criteria.
A little bit about prevalence.
Oh, yes. For headaches in general, though, it's more than just migraines, but there's a lot of people that are affected. Estimated 3 billion people with migraines or tension headaches in the world in 2016 when they did this analysis. It is one of the leading causes of disability in the US, and on an annual basis, it's pretty prevalent in both women and men, more prevalent in women, but just you can see here by this graph how many people out there are affected by headaches and migraines. It is very common both within what we do from a day-to-day basis, but just out in the world. If you hold, I guess everyone here tonight probably watching has either they or a close friend has migraines, but I was in clinic today and I just had all of the people working with us and I said, raise your hand if you have a migraine, and over half the people's hands went up. So it is very common. And it was common a long time ago as well. It was one of the earliest documented medical ailments out there. So you can see the picture up there was, this was an actual drawing on one of the Egyptian papyruses, where you can see the alligator tied to the person's head. That was the kind of like head pain that they were depicting in that. And a lot of famous people throughout history. So you are not alone, and you are surrounded by very successful and smart people as well. Talented, Ben Affleck. We're going to be talking about what we call primary headache disorders. So these are not headaches that are secondary to another medical condition, but things that are the condition themselves, migraine being the main focus tonight. There are other types of primary headaches. Tension headaches are kind of the more typical classic, just bilateral dolor headache. But there's also different subtypes of headaches that are far more than just what's listed here. Cluster headache is another example of one. Then there's also a whole category of secondary headaches. So things that are from another medical condition, such as high blood pressure or sleep apnea. So it's important to be thinking about both as we approach patients with headaches, but also as you have a headache and you're seeking medical care, it's important to see kind of primary care doctor and make sure that other things are checked up on that can be secondarily causing a headache as well. Okay, now to migraine criteria. This is the classification of headache disorders criteria for migraine. There are going to be people that don't fall perfectly within this, but this is kind of how we as clinicians categorize a lot of these, because you can get an MRI to work up headaches, but there's not one test that diagnoses a migraine. MRIs should be fairly normal, right, for patients with migraines. So we don't have one test that says, yes, it is a migraine or not. So we use these criteria to help group patients so that we can get them effective treatment, and also for insurance reasons to get medications approved, of course. But a migraine is headache that lasts anywhere from 4 to 72 hours. And then it should have the following characteristics, at least two of the following characteristics: unilateral pulsating, moderate or severe pain intensity, and then aggravated or avoidance of physical activity. This can be things like walking, climbing stairs, kind of things that interfere with your day. And then during the headache, you should have at least nausea and or vomiting, or light and sound sensitivity, or photophobia and phonophobia. These are a lot of the questions that we will be asking people as we are seeing them in clinic. But just because you have those symptoms, migraines are more than just those symptoms. There is a phase, there are four main phases to a migraine. It can start out as this, what we call the prodrome, and that can happen a few hours before the headache, up to several days. We're going to talk about more of these in detail later in the talk too. But you'll have the prodrome. Some people experience very specific sensory symptoms before a headache, which is the section I'm going to be talking about, visual aura. And then what we really think about when we think about migraines and when everyone says, oh, this is my migraine, is that headache phase. And then afterwards, you can have this after effect. Not everyone has all of these phases. They can be present in some people or some phases part-time, but this is the kind of onset, peak, and offset of the migraine kind of clinical spectrum. This is a similar diagram, similar shape, but it talks about some of the symptoms that people experience. So that prodrome, some of these you may have and not even realize that are migraine prodromes. I did not know, I do have migraines. I did not know that yawning was a prodrome until I became a neurologist. And now I know sometimes that when I am yawning, I'm like, oh, here comes a bad headache. But these are these kind of somewhat non-specific symptoms. So it does sometimes take someone to be more aware of them to realize that they're associated or not. But there are people that definitely will know, associate, and can kind of preemptively tell that they're about to have a more severe headache. Then that aura, which I'm going to hold off on until we talk about it later for the rest of it.
All right, so now we'll talk a little bit about lifestyle and triggers now that you have kind of an overview of migraine, some of the phases of migraine, just some context to understand it a little better. So we'll start with the case. So Virginia is a 30-year-old female who presents to the office for headache. She reports that headache started in her teenage years. They're severe, throbbing, located behind the right eye. They're often accompanied by nausea, being really bothered by lights and sounds. She has about one headache a week that fits this description. And she noticed they tend to happen a little bit more around times of stress or after getting poor sleep the night before. So this is very common description that I will get from a patient. We diagnosed her with migraine headaches. We just went over the criteria. She has, that throbbing unilateral headache, severe, associated with the nausea and the light and sound sensitivity. And she wants to discuss what might be triggering her attacks and what options for her headaches she can maybe start herself. And she would prefer to avoid medications if possible. So what kind of options can we discuss with her? So now with all of my patients, we start with lifestyle advice. So these are the things in day-to-day life that maybe can be modified to make headaches less common. So that includes paying attention to sleep, to diet, to adequate hydration, exercise, and relaxation. And you'll hear from people a lot that some of these things can commonly be triggers for headache, which is why modifying some of these lifestyle habits can be very beneficial. So sleep is very important in general, but certainly when it comes to helping to improve headache and migraine symptoms. Basic advice to make sleep better are things like having a bedtime routine. You should be getting up and going to bed at the same time every night, not having wild variability in that. Creating a healthy sleep environment. The bed should be a place where you go to rest. It shouldn't be where you eat your dinner. Turning off electronics and things that are going to kind of stimulate the nervous system about an hour before bed, not consuming large meals or caffeine before bed. In general, limiting fluids before nighttime is a good idea unless you want to be getting up frequently to use the restroom. And then things like exercise and stress reduction can be really helpful for getting better sleep. Insomnia is really common amongst people with migraines. So these are some very basic things that really everyone should work on to get good sleep. And certainly somebody who has headache or migraine. Now, I have a lot of patients ask me, what should I be eating? What is the right diet for somebody with headache or migraine? Now, when I put in headache diet into Amazon, these are the many pages that you get. All of them are a different diet, all claiming to be the answer to your headache dilemma. But really, we don't know. We don't know what diet is the preferred diet. Many have been studied and some have shown success, but nothing has pulled away as being the best. So keto diet, low fat, there's not one specific diet that I recommend. What I recommend to my patients is a well-balanced diet. So a lot of fresh fruits and vegetables, healthy proteins, whole grain, carbohydrates, and to eat consistently. So you might notice if you go long stretches without eating that you are going to be more prone to a headache or a migraine. So you should not be doing, the intermittent fasting is probably not the best idea. Making sure you're eating breakfast, lunch, dinner, getting food in you every couple of hours, a heart healthy diet. Hydration, super important, very easy thing to work on. Dehydration is a really common trigger for headache, tension headache, migraine headache. This is, again, should be a easy thing to adjust for better health in general, but certainly reducing the frequency of headache and migraine. Exercise. Now, many forms of exercise have been studied when it comes to migraine prevention. Aerobic, weight training, yoga, things like Tai Chi, all of them have been found to be effective. So anything you can do to get your heart pumping, to work on, strengthening and stretching muscles is going to provide benefit for, again, probably overall health, but certainly for headache and migraine. I'd like to also additionally draw attention to posture. There's a lot of things that can affect our propensity for headache. And if you develop issues in your neck or your cervical spine, that can definitely contribute to headache and migraine pain. This fact always blows my mind. For every inch of forward head posture, it can increase the weight of the head on the spine by 10 pounds. So
how many people just adjusted their posture with this slide? I did. I sat up straighter. I showed
yeah.
it in the clinic, and everyone around me was like, mm-hmm.
Yep, it makes you, pull those shoulders back because, we can see how that bad posture sort of leads to worse posture and what impact that is having on our spine. And how could that impact on our spine not be affecting our, kind of predisposition for headaches? So again, something to be thoughtful about, to work on. Strengthening and stretching the neck is something I recommend to really all of my patients. Weight loss. This is sort of a general thing, but weight loss has been found to be very helpful for headache and migraine. Can lower the severity and duration of attacks, reduce disability, and the strategy really doesn't matter. So working on your diet helps. Exercising, incorporating that helps. For people who need it, bariatric surgery can be helpful. And even weight loss medications have been proven to be effective. So again, just going along with the idea that being more active, eating a little bit more healthy is going to help overall. Now, stress management. This is always a tough one for people because there's, so many things that are outside of our control in life, but working on reducing stress is really helpful, not only for health in general, mental health, but also for headache and migraine. There's a lot of things people can do for stress reduction. Mindfulness relaxation practices are potentially a very easy, simple thing to incorporate into your life that can be helpful. Things like progressive muscle relaxation or body scans, kind of focusing on one part of the body at a time, really understanding the sensations there. Visualization, oh, I'm in a nice calm field. Meditation or deep breathing, journaling. And these are really helping us to gain some control over our body's kind of innate response to stress. So lowering that heart rate, slowing down that breathing, really calming us down, both physically and mentally. And things like yoga and exercise are good for stress reduction as well, kind of by a similar mechanism. I just like to draw people's attention to some of these mindfulness resources. So there are a lot of things out there. There's apps out there. There's websites out there. A lot of these places have guided exercises, so helping you practice some of that deep breathing, helping you practice some of that visualization. And these can be really helpful resources you can incorporate into your day-to-day activity. Again, some amount of stress is unavoidable, but how we deal with stress is within our control. So think about checking some of these out, take a screenshot or look back at these slides later. Just some good resources. I also like to draw people's attention to the American Headache Society has a number of resources. This is a QR code to find some different links about things like exercise and nutrition and headache and migraine, but also things like acupuncture, behavioral therapies, different supplements. So this is also a sort of a helpful resource when you're looking for a little bit more of a holistic approach to treating headache and migraine. Now, identifying headache triggers is important. A lot of the things we talked about are ways to sort of prevent our headaches and migraines from being triggered, but some really common triggers for people with migraine are things like stress, food, lack of sleep, but also things like pollution or the weather. This rainy day, I have a lot of migraine patients who are probably having a pretty miserable day today because when that barometric pressure changes, they notice their headaches are more common. Alcohol, loud noise or bright lights, and even certain medications can be triggering for headache. There is no one size fit all for this, though. Everyone with migraine is going to have different things that make them more prone to having a migraine attack. So while some of these are very common, it does not mean you are going to be susceptible, when the weather changes or when you have a drink of wine. The best way to identify triggers is really by keeping a headache diary. There's a lot of different ways to do this. There's journals you can find online. Some people like just a regular pen and paper journal. There are, many, many apps out there that you can use to record your headache symptoms. And then when you have a migraine that's triggered, really think back. What was different in the last day? Did I have 2 glasses of wine yesterday? Did I eat something a little different? I had some dark chocolate and I normally never do that. Was yesterday a very stressful day? That can really help you to identify the things that are, going to be more prone to triggering your headache and really picking up on those patterns. Again, everyone's a little different, so you kind of have to keep track for yourself. Food triggers, there is a way to be a little more systematic about this. Some people will consider doing things like an elimination diet. Let's say you have a few foods that you're a little suspicious about triggering your headaches. You can cut those foods out and then introduce them back slowly one by one and seeing, did I have that glass of wine and then have a migraine, shortly after the next day. Often there's a little bit of a lag, so it's not like an hour before. You might find that it's, 8 hours before, 12 hours before that you had that glass of wine and the migraine was triggered. So that's why really looking back at the day before is going to be helpful. And our migraines aren't always triggered by one thing that you identify as a trigger. There's often a number of things that sort of contribute that get you to that threshold. Everybody has a slightly different threshold, but a threshold at which your migraine is triggered. So I had a stressful day. the weather was bad, I didn't sleep well. That might put you over the top to trigger a migraine. So I like to think of it as really balancing out these kind of healthy lifestyle habits, good sleep, good diet, exercise, stress reduction, versus the unhealthy habits, um, to make yourself a little less prone to headaches. So our patient Virginia and her doctor discussed lifestyle improvements to help lower her risk of triggering a migraine attack. She's advised to keep a diary to help her better understand her headache patterns and triggers. And we start some supplements for migraine prevention, which we will talk about in a little bit.
I'm going to move on to visual symptoms and visual aura. I did want to emphasize that I think what Dr. Jicha made an excellent point of is that it is not one thing that necessarily triggers it. People always come saying, well, what's the problem? What's causing my migraines? And a lot of it is when people end up seeing me is to rule out some of those secondary causes. But ultimately, it isn't just one thing, and it's not a bad thing to not have a trigger sometimes. It is just something that can happen. I always like to say our brains like consistency. And so anytime that consistency fluctuates, sleep schedule shift, meals, hydration, stress, that all fluctuates and that changes that threshold of developing migraine. Our brains don't like to be pulled. So visual aura, well, this is an example. So a patient, Alexis, a 34-year-old female with a history of migraine headaches, coming to the office for unusual episodes of vision changes. It's happened 3 to 4 times, which she describes as kind of, has trouble putting words to it, but she says it's like a shimmering in the right side of her vision. It's there. It's on the right only, she thinks. And it lasts about 20 minutes, and then it was followed by a headache, but it went away on its own. This is a very common description for visual aura. It is, we'll say, what is an aura and what is visual aura? So auras are symptoms, sensory symptoms that can happen before the headache. Visual aura is specific because it is one of the most common ones that is experienced out there. Go to the next slide. Click again, actually. This one has animation. So for visual, that second phase of the headache, it will be typically 5 to 60 minutes. Should have, nice. See, I did some cool animation. It is sensory symptoms that will happen. For visual aura, they're going to get visual symptoms, and it can be anything that is typically a positive, is what the term I used to describe. So you can have an area that is not seen as clearly, kind of a blind spot, but it's associated with something that's on top of it, whether it's a shimmering, a zigzag, kaleidoscope. It's dynamic, it can move. That will typically last anywhere from 5 to 60 minutes. On average, I'd say about 15 minutes is what most people experience. There are people that can go longer than that, but for criteria, we like to limit it to 60. And then it is most typically followed by a headache. There are other sensory symptoms that people can have affected. So less commonly, but ones that can happen is that people will get kind of numbness, either in an arm or their face will feel tingling. People can have speech centers be affected, so they can have trouble speaking or even understanding sometimes, difficulty writing. Rarely will people get weakness, but there is a hemiplegic migraine where people get weak on one side of the body. Infrequent and certainly not something to be messed around with if you've never had this before. We don't like to label these very distinct neurologic symptoms as a migraine aura until we evaluate it. I have a slide on that part later too as a warning, but once you have these and are aware of what they are, particularly visual auras, you as a patient, when you have them, will be like, yep, here's my visual aura. You kind of learn what it is and what to experience. Next slide. Just to kind of reiterate with the visual symptoms. So they're temporary, they should fully resolve. They can be the kind of premonitory symptom to a headache. They're not always necessarily associated with the headache. Some people will just get the visual symptoms. Something that I like to emphasize is it's present in both eyes. It's usually starts off in one area of vision. It can be the central vision or off to the side, and it grows over minutes. But it is usually present in both eyes. People just don't check one eye or the other eye. but it's on the right side, for example. So people always say, well, it's the right eye. It is actually a brain problem. So if we think back to our, I don't know if you heard like the right brain affects the left body and vice versa, the same works for vision. So it's not that the left brain does the right eye, but the left brain does the right side of vision in both eyes. We see more of the right side of our vision with our right eye. So if it's all the way off to the side, it may just be shimmering out here in kind of just the right eye because it's not in the left eye's visual field. But when it grows into a larger area, testing, you'll notice it's in both. Next. This is a picture of somebody's visual aura. You can see this was one drawing where they had this kind of blurred spot with that shimmering edge. A very common description is this scintillating scotoma. I had to look up what scintillating was, which is just a fancy way of saying sparkling, shiny, bright. And then scotoma, partial loss of vision, a blind spot, blurriness. It is a very subjective thing. People will describe it differently, people will experience it differently, and it may not be the same thing every time, but generally it's fairly kind of stereotyped when it happens. The next slide, I think, has a bunch of pictures of, I found this table. Some of these are a little funky, but is a good description of that people experience a lot of different things. I like this to give people kind of a full spectrum of what other people might experience. I put more common ones on the next slide that will be just, if you Google image search, visual aura, these are artistic renditions of what people have experienced. Oftentimes when I get people sent to me, they don't know what a visual aura is yet, or their other doctor wants it evaluated. Sometimes a picture's worth 1,000 words. I just pull this up and I say, does this look like anything you experienced? It's like that one, top left. Very reassuring. It doesn't always look exactly like this, but kind of some variation of this. The picture on the left side of the screen is an artist drew what they saw over time. So as you can see, it evolved over minutes to grow, and that C-shaped edge was the leading wave of that visual aura as it expanded out over time and then eventually went away. So what is actually going on when we get a visual aura? Why does this happen in a migraine? When we looked at studies of kind of neuronal activity, vascular changes in the brain, we see this kind of wave of depolarization of neurons in the brain that's called a cortical spreading depression. And it starts off at certain areas in the brain, and you can see this kind of wave of depolarization that spreads across the brain, and it goes slowly at 2 to 6 millimeters per minute. When it starts out in the back of the brain is where we process our visual information, and you'll get this spreading wave of depression there. And it's actually that wave of depression that matches some of the visual symptoms. And as it spreads slowly, that's that C shape, as an example, moving over their visual cortex. It is not a dangerous thing when this happens, and it is fully reversible. It's just a interesting thing that happens with migraines and the changes within nerves and blood flow to them. This is my description earlier when I said it's coming from the brain. So the picture on the left is actually, it's an old artistic anatomy drawing from 1916, where they looked at the vision pathways, and you can see that the red is going to be the left visual field for this person, and it's all coalescing on the back side of the brain on the opposite side. The other picture is an actual MRI scan of someone's brain, and then the back part is where the visual processing occurs. When you're looking through each eye individually, if you look, the two circles here are if you were to look out of each eye, and you can see that the bottom picture, I don't know if you can tell on your guys, I put a little animation where it's kind of shimmering. It's very faint, but I tried to make my own rendition of what it would look like potentially for a very large visual aura. But it is the left half of both the right and the left eye. Just another example. This is a graphical rendition, but same thing. You can see over time, this patient experienced kind of a smaller scotoma where they have this shimmering area. Sometimes it's so small when it starts, people don't really realize something's wrong. And then over a few minutes, oh, there it is. And then it grows, and then it will slowly dissipate in about 30-ish minutes, up to 60 minutes. Can you have migraines without getting a headache? Yes. Some people can get just visual aura. There's a bunch of different terms out there. People will call it acephalgic migraine, visual aura, ophthalmic migraine. Some of those terms are a little more outdated. Ocular migraines is one I commonly hear. I end up putting that in my notes too, because that's what other doctors call it. But technically, I like the term visual aura. The other ones we're trying to phase out a little bit. But oh, silent migraine, I didn't even say that one, is another common one that I hear. People can be more or less, when this happens, it typically happens to people later in life. So people that have migraines when they're younger can get just the visual auras later. It's a very large mix of what people can experience. Some people will get just one or two of these and never have them again. Some people will get them happening fairly frequently. What do you do about them? Well, usually they're fleeting enough that by the time you make it to any sort of medication, they're kind of through their main stage, they're resolving. It's not worth it to take an abortive medication because it's almost done by the time you make it to a medicine. And if they're infrequent enough, it's not something that we like to give a daily medication to because there's more side effects from medicines, and generally we like to avoid medicine when possible. I approach it just like I do a regular headache or a migraine is really what I think of it as. It's how much is it getting in the way of somebody's life? And then stepwise approach it to regular migraines. So lifestyle is the foundation of all migraines, and then working on those different things building up. And really, if it is impacting somebody, then thinking about a medicine. But it's rare that we use medicine for this. Here is my stroke warning. Because if you've not had this happen before, I don't want people to assume that, oh, I have migraines, what I'm seeing is a visual aura. A loss of vision, particularly on the same half of both eyes, should be a stroke until proven otherwise, really, because the time sensitivity of a stroke is important. And if you click 2 more times, Crystal, I did an example of what it would look like. So you have your vision, and this is a visual field of somebody with a stroke that's affecting that red part of the brain. Time is of the essence, and it is just one of the stroke things. But typically with stroke, it is a loss of vision, a black loss of vision area that is missing versus the positive, dynamic, shimmering component to a visual aura. When in doubt, don't mess around. Always just come to the emergency room and get it checked out because that's the safe thing to do. But once you see us in clinic too, we'll go over symptoms as well. Okay. And the last slide for visual aura. It's nice to know the early signs because the earlier you recognize a visual aura, if you know you get migraines every time, you can theoretically take an abortive medicine. It's more effective. But really just being aware of what they are. They're not dangerous when they occur. They are something that you can kind of learn triggers for, approach the same way that we do regular migraines, and treat it like a migraine. So onto light sensitivity. Light sensitivity is a very common thing that we see with migraine. So here's an example of a patient, Erica. She's a 33-year-old with migraines, both with and without visual aura. And she's coming into clinic to discuss her light sensitivity. She has been having a lot of tough time at work because of her light sensitivity. She works in IT, so she's working with lights all the time, computers. She's in a bright office setting. It's really starting to inhibit how she kind of functions on a day-to-day basis. This is not an uncommon description that I see. This is a good example of somebody who has light sensitivity, but it's not always associated with their migraines. But people that have migraines are more predisposed to having light sensitivity, and they're very closely linked. You can have light sensitivity during a migraine attack and before a migraine attack. It's actually one of the most common symptoms in migraine to the point where it's in the diagnostic criteria. So photophobia, light sensitivity, is one of the diagnostic criteria for migraine. I always like to think about this as in neuro-ophthalmology clinic, the most common cause of light sensitivity from the eye standpoint is dry eye. The most common cause of light sensitivity from the neurologic standpoint is a migraine. It's really common. And it is both light sensitivity during the headaches, but also in between headaches. So people can have a lot of visual related symptoms. Exactly what I was saying. This picture I found is, even to me, this picture hurts my eyes. It's very bright. But one of the common things that I will ask patients, and when you're asking them about migraine questions, is when you have a bad migraine, do you just want to go close your eyes, put on sunglasses, lay down in a dark room? That's a very common thing that people will, even before they know that they have migraines, will start doing. They say, oh, when I get my bad headaches, I just go lay down in a room and close the blinds. Very common to have light sensitivity. And certain lights and types of light can feel worse. There are these overhead fluorescent lights, the ones that I always have in clinic. Inherently, someone comes in with headaches and migraines and they're sitting in the brightest room possible. But it's kind of a good test in clinic because I say these lights and they say, yeah, these ones are bad. Fluorescent lighting. Changes in light can be bothersome, and also screens can be really bothersome as well. There are things that we can do to help. I think thinking about overall headache and migraines, light sensitivity occurs throughout all of the phases. People can be sensitive mostly during the actual headache portion, that third phase. But you can see here, 90% of those with migraine aura also have photophobia at this time. It is kind of prevalent throughout. Here's one of the things that I always recommend to people who have light sensitivity is there's tinted lenses you can get. FL41 tinted lenses were not developed initially for migraines, but have been in follow-up data found to be one of the most helpful uses for this. It is a pink rose tinted lens that specifically blocks out some of the wavelengths in fluorescent lighting in that blue and green wavelength that are known to be more painful in migraines, but also any light sensitivity. They're pink lenses, but they make some cool ones online you can find. You can get them built into glasses if you like them. I always tell patients, go online, find a pair that's not expensive, make sure you try them out and like them. And if you do like them, a lot of optometry shops or online places can have those built into lenses. I like these lenses particularly because a lot of people, when they have light sensitivity, will do things like put on sunglasses. It's important to not use sunglasses indoors as much as possible because that adapts you to that dark environment. Think about if you go to the movie theaters, for example, and you're in the movie for 2 hours, when you walk outside and it's really bright, that hurts everybody's eyes, whether you have normal light sensitivity or not. If you're wearing sunglasses all the time, you kind of set that adaptation threshold lower. These lenses are nicer because they let a lot of the normal light spectrum in, so you're not getting overly sensitized to dark environments. But it blocks a lot of the painful light. It's good to use on any time, right? We use them in a bright day, but indoors, particularly screens, things like that, without having to dim all the lights inside and turn the screens down, if this can be helpful. They make cool ones. This is my new slide I added this year because I went online and I found a website that makes stylish FL41 tinted lenses, and there are 1,010 results. I should buy some in clinic to trial. Yeah, they're cheap. They were like $15.
Very nice.
Yeah. So my mnemonic for light sensitivity that I made up, give yourself a break. Yeah. So breaks from prolonged screen time. We inherently don't blink when we're looking at screens, which that dry eye and that overfocus and the eye strain you get from staring at a screen can cause worsening light sensitivity. And then a lot of the same things that we do for migraines, even in non-migraine patients that have light sensitivity, I use the same lifestyle modifications because it's that threshold and that sensitivity type disorder. So regular sleep schedules, exercise, hydration, healthy lifestyle choices in general. So the patient that we had earlier as the example, Erica, she got the FL41 tinted lenses. She found a very cool, stylish pair, as you can see. She put in some eye drops when she was using screens just to help minimize any effect of dry eye. She did a lot of the lifestyle modifications, and 3 months later, her symptoms are gradually improving. Light sensitivity is not something that is an easy fix or an easy cure, but it's something that you can slowly chip away at, and then kind of looking back, realize how far you've come.
Absolutely. So we've talked a lot up to this point about things you can do yourself at home. You know, you don't need a doctor to order those FL41 glasses or to work on some of those lifestyle modifications. But when do we need to see a doctor? And that's certainly when it comes to evaluating possible secondary causes of headache. So things that aren't intrinsic to our body, our makeup, and how our system works, things like migraine headache. So this is the case. Jenny's a 62-year-old female. She has a history of high blood pressure and diabetes, and she's coming in for headaches. She's never had a headache before, so this is new for her. Her headaches are severe. She is throbbing in the right temple and eye. She has nausea and light and sound sensitivity. So Up until now, it's sounding a lot like migraine headache that we've discussed before. But she's also started to notice some decreased vision in her right eye that she's noticing even when she is not having a headache. So Jenny is understandably anxious about her symptoms and wants to know what's causing her these headaches. She asks if there's any evaluation that is needed before you discuss treatment options. Do her symptoms require further evaluation? So again, while there are, while the headache she's describing sounds a lot like migraine that we've discussed previously, there are a few things that might make us interested in evaluating her further and getting evaluated by a doctor. So just some general guidelines for when to see a doctor for evaluation. These are what we call red flag symptoms. So new onset of headache. So she's a 62-year-old woman, never had a headache before, is having a new headache. That is sometimes cause for concern. So if this is a new headache, or a change in a previous headache pattern. Let's say Jenny has had migraine before, but previously she was having migraine, once a month, a couple times a month. Now she's having a migraine every day. That is cause for concern and warrants further evaluation. If this is a sudden onset, very severe headache, so we think of headaches that go from 0 to 100 in, the matter of seconds to minutes, that is cause for concern. That can sometimes indicate a secondary cause of headache that warrants further evaluation, even if you are somebody who has a previous history of headache or migraine. If you're having visual changes or other deficits, our patient in that example starts to have some visual issues that are persisting even outside of the headache episode, and again, that are new for her, that definitely warrants further evaluation. And in general, it's a good idea to see a doctor if you're having head pain that's interfering with your daily function. So even if this is run-of-the-mill migraine, it is impacting ability to, function and do the things that, you need or want to do, that definitely warrants evaluation and treatment. There are a lot of causes of secondary headache. Some of the most common that we think of are things like headache related to high blood pressure, headache related to sleep apnea. So this is a condition where, you're not getting adequate oxygen at night while sleeping. And both of these are easily treated. Headaches attributed to use of or exposure to a substance. Medications, a lot of the medications that we use to treat other things like high blood pressure can actually cause headache. It doesn't mean that you don't take your blood pressure medicines or you don't take your medications for diabetes, but maybe there's a different choice that can be considered in some of these situations. Or, if it's an illicit substances, a lot of the illicit substances can contribute to headache as well. And then one of the most common headaches related to an infection. So if you're having an illness, pretty common that people have headaches during that as well. And these are all examples of, again, secondary headaches. So something else is causing the headache that's being experienced. Some other really common secondary headaches that I see in clinic, cervicogenic headache. So this is a headache that's coming from the cervical spine, so the neck. This is usually accompanied by a reduced range of motion of the neck. So instead of being able to turn your head fully in all directions, you might be limited. Maybe you only move a little bit, you can move a little bit up. And it's often triggered by those neck movements. So the cervical spine there. And this is usually caused by nerves getting pinched in the neck. Things like physical therapy can be really helpful for this. Occipital neuralgia is another kind of related disorder that I see commonly. These are often caused by nerves that are getting pinched either by the neck or by the neck muscles. It's often associated with some slightly different symptoms, things like numbness or tingling in the area that nerve covers. The occipital nerve is kind of in the back of the head here and radiates up to the top of the head. While you can have tension headache and migraine headache pain in this area, if it's associated with things like the numbness and tingling, occipital neuralgia might be the more likely culprit. People often have a tenderness spot in the back of the head where that nerve is kind of first coming up and wrapping around, that might be supportive of occipital neuralgia as well. Now, we talked a little bit about red flags. What are some green flags? So when I hear these things in the history that I gather from patients, these usually reassure me that this isn't a secondary headache disorder. Again, a headache being caused by something else wrong in the body, but maybe more likely a primary headache, something like tension headache or migraine. So if headache's been there for a long time, you've had this headache since you were a kid, that's reassuring. If you're a woman and you've noticed this headache has occurred in time with your menstrual cycle, that's really common in things like tension type headache and migraine headache. So that can be reassuring. If you're having headache-free days, so again, you're not having a headache every day, you have time without head pain, that's reassuring. Or if you have close family members with headache, things like migraine headache does tend to run in families. So it's not uncommon for me to have a patient who noticed, their mother and their grandmother both had the same type of headache disorder. So all of these things can be reassuring. Doesn't mean if you don't have the other things, you don't see a doctor, but these are the things that I listen to reassure me that we're dealing with a primary headache disorder. Now, medication overuse. This is an important concept for anyone with tension or migraine type headache. So we'll start with a case. Henry's a 48-year-old male. He has a history of migraine and tension type headache, and he's coming to the office to discuss worsening of his headaches. So he went from having headache 3 days a week to now having them daily. He's been treating with over-the-counter medications like ibuprofen and Tylenol on a daily basis just to keep himself functioning. He wants to know why the headaches have increased in frequency despite, his stable health and lifestyle factors. So what is a likely cause of his worsening? So for people with primary headache disorders like migraine and tension type headache, there is a phenomenon called rebound headache or medication overuse headache. And this is a lovely concept where you're taking, more medication to treat headaches, that actually can sometimes contribute to developing more headaches, which leads to this lovely cycle where you're taking more meds, which are giving you more headache, and then you're taking more meds. So this can be really difficult, an important concept to be aware of. So in general, how much is too much? So it depends on the type of medication you're taking. These are some general guidelines, although these are by no means exact rules for people. Things like Tylenol or ibuprofen or aspirin, if you're using them 15 or more days in a month, that can contribute to medication overuse or rebound headache. Combo meds like Excedrin, 10 or more days a month, opioids or things like Fioricet, 10 or more days a month, or triptans, if you're using those 10 or more days a month, can all contribute to increased frequency of headache and increased disability from headache. Again, these are general guidelines. This is typically with months of overuse of these medications, but really important to keep in mind so that you're not over relying on the acute medications that you're taking, because again, they can make things worse. Now, if you're needing medications this often, that's when you should be talking to a doctor because there's probably other things that need to be worked on so that you're not having a headache or a migraine every day or 15 days a week or a month that you need to be treating with medications like this. So what's our approach to treatment?
Okay, and I always like to remind people that the brain doesn't know what you took the Advil for. So if it's taking it for another reason, it is still technically a day that your body sees Advil. So I know
Yeah, so if you have migraine, that's an unfortunate thing. And sometimes you need those medicines for other purposes, but it might be a good reason to talk to your doctor who's treating your back pain or your arthritis pain about what other options might be available to you. So now let's talk a little bit about medical treatment options. So Tanya is a 41-year-old female with a history of anxiety. She's coming in for headaches. The headache started as a child, so it's a nice green flag. They're severe, they're throbbing, squeezing in the front of the head, and she has associated nausea, light and sound sensitivity, and neck stiffness. Sounds like migraine. They have increased over the last 20 years and are now occurring about 3 or 4 days a week. So she's never seen a doctor for this before. She was previously managing with lifestyle changes, avoiding triggers, over-the-counter medications, but now it doesn't seem like it's enough to manage her symptoms, and she wants to know what her next steps might be. So what can we do to better help Tanya control her headaches? When it comes to medical therapy, there's sort of two broad categories that we think of. That's acute treatment and preventive treatment. Now, if somebody's having headache once a month, couple times a month, we might stick with acute medications. You just need something to take in the moment to help treat your headaches. But Tanya is now having headaches up to 16 days a month. So in that situation, we start to visit this second category of treatment, and that's preventive treatment. So what can we do to make it so that she's not having 16 days of headache in a month? Now, there are many goals of preventive therapy. In general, things like making headaches less frequent, making them less intense, making them last a little, not as long, making us function better, less disability, giving us better quality of life, making it so that we're not having to take meds as frequently to treat the headaches and reducing our risk of that medication overuse. Now, this is not a one size fit all, treatment. We sometimes have to make our way through a couple of treatment options before we find the thing that works best. So it means, again, working with your doctor, really treating it as a partnership and trying to find the medications that are going to best work for your headache and migraine and for your lifestyle. There are a number of categories of preventive treatment that we visit, and not all of them were designed initially to treat headache and migraine. So, for instance, the first three categories are the ones that we use most commonly, and these are medications that were designed for completely different purposes. Antihypertensives, so things we use to treat blood pressure, seizure medications, antidepressant medications, and then we have things like that are a little bit more targeted, like our CGRP targeting therapies, and Botox. So again, not all of these were created for migraine. The only ones here that were created for migraine are the CGRP targeting therapies. These are a little newer, but work very well. But some of these other medications, if you're somebody who has some issues with high blood pressure, then maybe an antihypertensive medication is a good choice for you. Things like our antidepressants and anti-seizure medications might be able to treat other things as well. So if your doctor brings up a medication like propranolol or topiramate, even though they weren't created for headache, they might be really beneficial for you. And then if you're somebody who's having headaches more frequently, 15 or more days in a month, you might be somebody who qualifies for Botox as well. So a lot of different options. And again, it's about working with your doctor as a partnership. Now, when it comes to acute therapy, there's a lot of different options as well. There's anti-inflammatory meds, so things like ibuprofen, Tylenol, aspirin, or things that are maybe a little more specific for migraine, things like our triptans and our Gepants, sumatriptan or Imitrex, rizatriptan, Nurtec, Ubrelvy. You might have seen these advertised. And then anti-nausea medications. These can be helpful not only for the nausea that's really common in people with migraine, but also independently, they can be helpful for the pain of headache and migraine. So these are some medications your doctor might recommend. When it comes to acute medication use, there's a few tips that can be really helpful. The earlier you take your medication, the more beneficial it's going to be. So we talked earlier, Dr. Spiegel talked earlier about, some of those prodromal symptoms like yawning, or certain cravings, or sometimes people just get like sort of a funny feeling, some fatigue or irritability. That might tell you that you're about to get a migraine attack and will give you a good clue of, oh, hey, I need to make sure I have meds available. Some medications like the Gepants, things like Nurtec and Ubrelvy, even work before the migraine sets in this prodromal phase. So really helpful to know kind of what those symptoms might be for you if you do experience that. And a headache diary can be a good way to do that. Treating early. The earlier you treat your pain, better. This doesn't matter what type of pain you're treating. But when it comes to headache and migraine, as soon as you get that kind of, first little bit of pain or discomfort, your meds are going to work best if you take them during that phase of the migraine, as opposed to waiting until it gets to that 8, 9, 10 out of 10 pain. And then try to limit use of your acute medications as possible. If you're still having 15, 20 headache days a month, you might need to talk to your doctor about increasing the preventive treatment that you're on. I have many patients who are on more than one preventive treatment because that's what they need. And if that cuts back on how much you're needing to use acute medications, then it's often worth it. There are a lot of non-pharmacologic therapy options. We talked about a little bit about some of these earlier, and I gave a resource QR code for some of these, a little bit more information, but there are a lot of things outside of medications. Complementary and alternative medicine approaches, things like acupuncture, physical therapy, massage, behavioral therapy options, things like relaxation, mindfulness, cognitive behavioral therapy, or biofeedback. Some of which we have available at UCI. And then things like supplements. So magnesium and riboflavin are some of the supplements I recommend most commonly because they're well tolerated and they have good evidence for being helpful for migraine prevention. Magnesium in particular is we think it might be helpful for migraine aura prevention. So if you have frequent visual aura, this could be a really good choice for you. And it's usually very well tolerated. We usually recommend around 400 milligrams of magnesium or 400 milligrams of riboflavin if those things are of interest to you. You know, good to talk to your doctor about, make sure they don't interfere with other things, but typically this is very well tolerated and it's something you can initiate on your own. And then neuromodulation. So there's different devices that we can also give for migraine acute and preventive treatment. So definitely good things to talk to your doctor about. Don't think it has to be all pharmacologic medications. There's these other options as well. So our patient, Tanya, decides to trial venlafaxine for migraine prevention, and she's given rizatriptan for her migraine attacks and naproxen for her tension headaches. At her 3-month follow-up, she's noting a decrease in her headaches to 1 per week from 3 or 4 per week. And when she does have migraine attacks, the rizatriptan works well within an hour. So this is what we want to hear when we have somebody who started on pharmacologic prevention. And it sounds like she's had a really good response, which is wonderful. So that about wraps us up.
Thanks, everybody.